Good morning, everyone, and welcome. My name is Amira Wis, and I'm a non-resident scholar at the Middle East Institute, and I'm a professor of global health and epidemiology at George Mason University in Virginia. I am pleased to welcome you to today's webinar on important issues of mental health and displacement, particularly among refugee populations in the Middle East and North Africa. Today's one-hour webinar brings together leading practitioners from the region who are on the front lines working to address the mental health epidemic in the region, which disproportionately affects IDPs and refugees. Through their experiences with conflict, displacement, relocation, resettlement, and return, refugees face violence, discrimination, poverty, and insecurity, often resulting in trauma and a variety of mental health issues which live with them and devastate their entire communities. With today's webinar, we will seek to understand the breadth of the mental health challenges faced by displaced people, as well as the geographic, political, and institutional challenges faced by aid workers and service providers attempting to address these issues. This is the fourth event in a series to launch the Middle East Institute's new Migration and Displacement Initiative. The other three events in the series covered the impact of COVID-19 on displaced individuals and communities, gender and displacement, and the participation or exclusion of refugees and IDPs in the region's protest movements. You can access these past webinars by visiting the link that's going to show up in the chat box. Today's webinar will build upon the themes of the previous three talks, including the increased vulnerability of refugees, the susceptibility of refugees to violence, and the discrimination that exists in both host communities as well as in the public health systems. It's been a particularly challenging time for refugees from a mental health perspective due to the combination of ongoing stress and mental health challenges faced by refugees in combination with the COVID-19 crisis and several recent events, including the Beirut blast, ongoing conflict in Syria, and recent events in Greece with the rejection of refugees arriving on Greek shores. To help us understand the ways in which these issues and events intersect, we have three panelists with extensive experience in clinical psychology and clinical psychiatry in refugee settings. First, we have Mia Atwi. She is joining us from Lebanon and is a clinical psychologist and is the co-founder and vice president of Embrace, a leading mental health NGO in the country. She has worked in the field of mental health in Lebanon for the past 10 years and is a published researcher in the field. Next, we have Dr. Assam Dawood. Dr. Assam is based in Greece, but recently was in Lebanon to help with the Beirut blast recovery. He is a co-founder and mental health director of Humanity Crew, an international aid organization specializing in the provision of first response mental health interventions to refugees and people in crisis. Finally, joining us from Turkey is Dr. Mohammed Abu Hilal. Dr. Mohammed is a clinical psychiatrist who founded Syria Bright Future, an organization that helps Syrian refugees, particularly children, cope with trauma and provides psychosocial activities that help children deal with the challenges of being refugees. Himself a refugee, Dr. Mohammed fled Syria in 2011 after being arrested and tortured by the government of the Syrian president. I look forward to a productive and expansive conversation over the next hour. We will be taking audience questions through the Zoom Q&A chat feature, and you can all find that on your screens. You may submit questions at any time throughout the event, and I will take as many as possible. For those of you who are joining us on the live stream or by phone, you can also submit your questions by emailing events@mei.edu. Okay, so I'd like to start off by posing the first question to Mia. Mia, in the wake of the Beirut blast, we can see the impact of this trauma on the people of Lebanon. What have been the outsized impacts on refugees, and how does this shape your work providing mental health resources?
Thank you, Dr. Amira, for the introduction. As you may know, this is the third week after the Beirut blast, and we are still really trying to recollect ourselves as a community and as mental health professionals and as leaders who are trying to lead this very difficult and very complex disaster relief operation with minimal assistance and with actually no assistance from any government resources. And most of the work in terms of disaster relief currently is being done by non-profit organizations in the country. We are still yet to understand the impact of the Beirut blast on not only the Lebanese community, but also the refugee community, who is also very much impacted by the explosion, because from our work on the ground, we do not have yet specific statistics or numbers, because as you may already also know that there are very few really accurate data collection tools that take place in Lebanon. And this is what is making the relief work also very much more difficult for us, in the sense that the non-profit organizations are currently doing all the data collection on the ground in terms of the number of homes that were damaged, the number of families that have lost their homes and have had to flee. As you may also have heard, we still have people who are under the rubble, around 52 people who are missing still. So we do not yet have a clear idea about what is the impact on both the tangible, the psychological impact, if you want to say, on both the Lebanese and the refugee community. We do not have accurate numbers that tell us how many refugees are living in the areas that have been destroyed. We are collecting this data as we go day by day, mapping individually and as organizations the different homes and the different roads. So we are still seeing slowly what are the ramifications of the Beirut explosion on both populations, especially psychologically, and also mapping actually the specific numbers of families that have been damaged in the refugee and the host communities.
Thank you, Mia. Let's see, I will then direct the next question to Dr. Mohammed, working in Syria and Jordan. What has been your experience working with refugees on mental health issues, and what obstacles do you face? And when you're done describing that, it may be worthwhile to sort of think through what are some of the commonalities with what Mia had just mentioned.
Yeah, thank you, Amira, very much for the introduction and this opportunity to talk about very important issues that facing displaced people and refugees in the region. And unfortunately, our region and countries has been exposed for like waves and waves of catastrophic crisis, actually. Since Palestinian problem, then Iraqis, refugees, then Syrians, and we see the problems all over. Actually, we always talk about traumatic events that happening during crisis or catastrophic incidents. And this usually has, we talk about three categories of psychological problems that may be faced. One is like mental illnesses that already there, but have been affected by the crisis. And we talk about mental disorders and psychosocial problems that happen because of a crisis. And we talk about some psychological problems because of the humanitarian aid that is provided to needed people. So this is three big categories that we talk about when we talk about the effect of crisis on mental health and psychosocial support. I mean, everybody knows that a lot of traumatic events has happened, incidents like for Syrians, they've been exposed for displacement, killing, kidnapping, injuries from bombardment, and even chemical weapon attacks. Also, like multiple displacement that happens, that sometimes up to 9 times people displaced inside and outside the country. People have been exposed to exploitation, sexual violence, detention and torture. So all type of traumatic events. So all this can cause tremendous effects on life and psychological well-being of refugees and IDPs. I mean, to just simplify the effect, we usually talk about 70% of people will have like mild problems, psychological problems that can be helped by a very simple interventions. And we talk about like 20% of people usually develop a moderate psychological problems that need some type of what we call it focused but non-specialized services. And we talk about like 10% of people, they may need specialized services and they have like a mental disorders they need to be cared of. Usually this percentage in stable situation about 5%, but after a crisis, it's like become around like 10%. This is rough numbers. I mean, there's a lot of studies and needs assessment there, but this is just to draw a picture about the effect that has the displacement and refuge and all the events on the psychological well-being of people. Thank you. You are muted, Dr. Amira.
Sorry about that. You mentioned that 10% may need specialized services. How do you provide those specialized services in the setting where you are?
Yeah, actually, I work in Jordan and also in Turkey and also supervising work inside Syria. Usually, I mean, because of shortage of psychiatrists, number of psychiatrists in Syria. So there's a programs by WHO called MHGAP, where a general practitioner and the general doctors can be trained on psychological and psychiatric management of mental disorders according to WHO curriculums. And then they can be provide such services to people who may need psychotropic medication for their illnesses, either PTSD or schizophrenia, depression, and all other mental disorders. So this is for the 10% that we are mentioned, but of course, not all these people are receiving the care they need. Still, there's a lot of shortage, especially we don't have psychotherapy. Like psychotherapy, we lack a lot of this specialty. Because usually, like in Syria before revolution, there was no such a profession as psychotherapy. So it's difficult. It's only few professionals can provide such specialized services for people. So this is actually the situation inside Syria. And of course, the other percentage of people, they receive other type of like psychosocial activities that can help them cope with the situation.
Thank you. Thank you for that. So for the next opening question, I'm going to turn over to Dr. Assam and ask him in his experiences, how are refugees coming to Greece, many of which have been commuting by boat. A lot of them seem to need extra mental health care after facing this extreme danger. Can you share with us your experience and talk a little bit about what are some of the mental health dangers that you're seeing in this very vulnerable population?
Hi everyone. The situation is not different than any other stop or stage of this displacement journey. We are talking about the same people, the people who are in Syria or in Turkey or crossing the sea now, or refugees in Lebanon. They all share the same experience. It's different stages of their journey to safety and for a better life. And maybe it's surprise for people that actually crossing the sea is not that traumatic event. We are talking about repetitive traumatic experiences that the people are going through since the war started in Syria. So, and this is the problem, because we are looking our Western approach of psychology and psychiatry and how we think about trauma is taking us to think about this single event. Even in your question, like about the sea. And even if you look at the book of, our Bible as a psychiatrist, the Diagnostical Statistical Manual, the DSM-5 for psychiatry diagnosis, it's talking about in PTSD, it's talking the post-traumatic stress disorder, by definition, is talking about a single event. There is no definition or there is no diagnosis that talks about a repetitive or a recurrent multiple traumatic events. And this makes us make all the services that we provide to the IDP or refugees a little bit complicated, because we are actually approaching a problem that is not exist. Everyone think or that PTSD is the problem that we are dealing with. It's they will be afraid from the sea or from the bombing or etc. But no, it's not like this. The traumatic event is it's a continuous one, that the fight or flight system, the body response, fight or flight that starts in Syria is a one act, one process that starts in Syria, and maybe it could be shut down in Greece if they feel a little bit safety. So the problem is that we forgot that there is a journey of there is a psychological journey, if I can say that, for each refugee. It's not just the geographic one, and this journey is full with multiple traumatic events that the end, or what we see on refugees is a total different clinical presentation than what a PTSD, the Western one of a single event is. It's a lot of attachments problem for children. It's a lot of emotional issues, problems with planning, reasoning, abstraction, how they can plan the day. It's not just about nightmares and thinking about the trauma itself. And what makes our experience in Greece special, and somehow that we actually saw the people in a stage where they start feeling a little bit safe, because they are in Europe, they crossed the sea, they are now in somehow they did it. And because being in Lebanon or in Turkey or in Syria is still for their psychological state that they are still in the region, and crossing, even if it's just few miles in the sea, and reach one of the Greek islands, which is very close to Turkey, it gives them some kind of a sense that they did it and they are safe. And then the thing that we are actually, the symptoms, the signs, the things that we see in Greece is a total different than things that we actually deal with in Turkey. And it's actually more about, all the, I can say that, it's this kind of a sum of all things that happen to them. And the problem is that it needs a lot of work, and it needs a lot of professionals and trained volunteers, something that is not there and does not exist. So I prefer a single act of prevention to be done in Syria or in Beirut, for example, to do the right intervention on the right time when that trauma is happening. It's much easier and to prevent than later to treat, as we see the consequences in Greece months and years later, which is, as a psychiatrist and psychotherapist, I can say it's really hard to deal with. So we need to start thinking about how we can prevent than to treat.
For a lot of us who are not mental health experts, can you explain just a little bit more about the DSM and whether or not multiple traumas are addressed there? That's one of the questions that's coming through. Complex PTSD, one of the audience members is asking, is that excluded from the DSM?
Yes. You know, I will try to make it in a it's like this. The DSM-5 it's a huge project done by the APA, the American Psychiatry Association, every 3 to 5 years. And as it's called the Diagnostic and Statistical Manual. In medicine, the only branch of medicine that doesn't have a cause is psychiatry. You know, if you have a heart attack, if you have a diabetes, we know what caused this. In psychiatry, unfortunately, we don't know. So to make a diagnosis, we based it on symptoms and sign and statistics. So this book is actually comes to make a lot of research during these 3 to 5 years. And they, at the end, they say, okay, these 9 symptoms mostly comes together. And if you have 5 of them, then it's called depression. And this is the book. The book is about statistics, like what depression is. And that's why every 5 to in each edition, we saw new diagnosis, different diagnosis change, criteria change, and etc. About trauma, there is only, like, there is several, but the one that we are talking and relevant to us is the post-traumatic stress disorder. And by criteria, the criteria say that there is need to be a single event that threat the life of the person, more or less. The problem is that this is right. This is really, actually, people can develop PTSD, but if you know, walking in New York street and a car hit you, or someone, you know, you saw something, or someone attack you or assault you. But as you said in your first question, the opening question, what about the refugees that cross the sea? We know that they have been refugees in El Yarmouk camp, then they moved to Turkey or to Lebanon, and in their way they saw ISIS and bombing, and then they moved to Turkey and they took this. So which trauma actually will do this, the PTSD? Which one of them? So that's why it's not relevant. So all the research, all the money, all the resources of all the ministries, it goes to this. But actually what we see is more the recurrent multiple traumas, and this is not part of the DSM-5, and it's not a diagnosis, and it's actually caused something more, what one of the audience say, the complex PTSD or complex trauma, which is it's not a little bit, it's a total different presentation. The problem is, and the important about being diagnosed and have a title and being part of the DSM-5, it's money. Because if it's a diagnosis, if it's a disorder, then the authorities, the Ministry of Health will invest money in research. It will be like an ongoing research about this. They will develop medication for this, and etc. So why it's not being part of the DSM-5? I can guess, you know, as a Palestinians, we like conspiracy. We believe that every time someone like want to do something bad to us. But in this case, I actually think it's the right thing, that it's about money, because if they will put complex PTSD part of the DSM-5, then United States of America, for example, need to pay a lot of money for a lot of population inside the country that will be diagnosed with mental health issues. In Paris, all the immigration and all the poor people, they will be diagnosed. Then the insurance companies and the government, and they need to start taking care of these people. So That's why there is no interest to put complex PTSD, for example, in my opinion, as an entity inside the book of psychiatry. But for us, it's not about money. For me, it's the problem that there is no enough research, there is no enough knowledge about it, there is no enough cross-learning, and etc. That's what makes working with this population very hard. And one of the other things that makes it like more hard for us, that all the mental health support that comes, which mostly comes from the West, come with this kind of approach, with this kind of attitude of Western approach, that it's about a single event. And things that works for the single event works for PTSD. It's not just that doesn't work for complex trauma. Sometimes it actually do harm, and this is the problem.
And, following up on that, I think something that we do know about medicine and public health is that often the latest information, the research doesn't really get to the practitioner for at least a decade. One statistic says it takes on average 17 years for practice to change based on research. And so in the mental health field, we have even more challenges, because the progress in understanding mental health disorders has been slower than in other fields of medicine. And so that is, definitely an ongoing challenge globally. I wanted to take just a moment to see if any of our other panelists would like to add anything to what Dr. Hassam just said.
Yeah, if I may. Actually, I want to add to what Dr. Hassam said. Not only repetitive traumatic events, but also the adjustment with the daily life stressors have the same effect on the psychological well-being of people. So as Dr. Hassam said, that if we focus only on one diagnosis or narrow window to see the issue, is sometimes will not be helpful. And actually, for me, is like when you talk about diagnosis, you talk about problem inside the person, but what I think is the problem is not inside people, it is around people, it is in the environment of the it is the causes that resulted in all these catastrophic events that caused a problem. So now we are talking, we prefer to talk about psychosocial approach, not medical approach, psychosocial approach, human rights approach, that we think that we need to tackle not only the psychological state in the person, but also his near community, family, and the bigger context, because all of them are interconnected with each other to cause any symptoms or problems that may appear. So this is actually very, very important. And even also, Dr. Hassam said that even when journalists ask questions, even when donors ask, even when whatever media talk about things, they talk it in different way than what we see on the ground. And this is actually a big problem. Even academics sometimes they can come to do a research on PTSD, although this is not the problem that we talk about. We have a lot of other problems that we need to do investigation about, more than just PTSD. But as Dr. Hassam said, that's maybe this is what they can get like a good research for, or money, or whatever the causes. But this is actually, unfortunately, this is the reality in dealing with the psychological problems with refugees. Thank you.
So one of the questions that we have here is about the relationship with donors, and how do you face those challenges when, like you were saying, oftentimes donors are focused on a specific health issue when you are facing a real need that's not in conjunction with what their funding focus is?
I think I may ask this. It's funny and sad. It's not about that they wanna, for example, fundraise, if like fund PTSD, and we say no, it's complex PTSD. The problem is it's much bigger. Like, mental health is marginalized even in the Western world. Even in New York, it's marginalized. So just imagine what mental health is situation in the field of like humanitarian aid or displacement or refugees and war zones. Is the last thing they think about. It's like if a big NGO or all the, like even the UN, if they provide some kind of a service like this, it's like a privilege, it's like an extra thing. We have another project of mental health, or like if it comes like after 1 week or 2 weeks is excellent. Like it usually, after months or years when they finish with everything else. And so for us, for example, who provide this service in an area like this, so just imagine what the proportion of the funds that goes to mental health is. Nothing. And then for me, for example, for what I do is like, which is first response, to comes and ask for first response. Like they will say, no, for Beirut, people need food now. People need shelter. That's right. I'm not saying that's right. They need food, they need shelter, but they are human beings. They need also someone to listen to them. When we open our crisis text line and for the people in Beirut, I went to sleep. I thought maybe 5 people will text and I will manage it. I don't need like volunteers to do this. I don't need to, wake up people like my professionals to join me. I wake up with 300 in less than 6 hours. So the intervention that we did there, like people really, no one asked about money. No one, I'm not kidding. No one asked about money or food. They were asking about like, I can't go to take a shower because I'm afraid something will happen. Every sound that I heard, I jump, and stuff like this. And we saw how intervention that took like 1 hour of texting. We don't have a phone line. We didn't succeed to be in Beirut. We saw the results on people. So to come and ask money for this, unfortunately, we stopped it after 2 weeks because it cost money. We don't have any funds for this. We did this in our own time. Actually, I just want to say thank you to the team who did it. Actually, the team who did it are a psychologist from Gaza who did this for free. They are stuck in Khartoum because of the COVID-19 after they finished their PhD. And they were the only team who were dedicated for 14 days, 24 hours in 6 PhD clinical psychologists who did a great job. They provide something around 700 people received support for them for free, but we couldn't, it's cost. So to find funds for this, it's hard. And we saw, for example, local NGOs, not even not in Europe, not in Lebanon, sorry, in everywhere in Middle East, saying, let's a campaign for supporting the people of Beirut and like for food. And you can see like in 5 minutes, like they have like $10,000, $20,000 or something like this. For mental health, you rarely have like 1,000. So the problem is that there is not much. And if you're talking about first response, it's not exist. And if there is funds like this, it's like this by the big NGOs who has the good machine of fundraising. So, and they don't make any compromise even for funds like this. So it's a survival, fight every day that we have, but it's a problem. But this is part of the awareness. This is part of being here and talking about this, that we should know that. We have to know that we are supporting human beings, and you can't just provide food and shelters. Yeah, that's it.
Would anyone of the panelists like to add anything specific to this situation? Go ahead, Mia.
Yes, I'd like to just comment on the last few things that Dr. Dawood mentioned, which in the last few weeks, actually, we have seen a big response from donors towards mental health. I think this is, it's been a very, very long time since we've had a disaster this big. But this time around, honestly, there has been a lot of questions and concerns and requests for proposals from both local and mostly international donors and governments to actually tackle the mental health effects of this disaster. So with the awareness that we have been doing in Lebanon for the past 7 years, 10 years, at least from the part of the organization I represent, which is Embrace, I think we have been able to change the conversation in Lebanon for some time to be able to talk more about the importance of mental health and highlight it in the community. And yes, I do agree with Dr. Dawood that a lot of the funding priorities for Beirut right now are coming in terms of rebuilding, reconstruction, medical aid, and food supplies. But at the same time, there has been a relatively strong response towards mental health, with many requests being asked of us. We will wait for the next few weeks to see what will materialize of all of these proposals and from possible funders. But the mental health needs, again, as he mentioned, the mental health needs are enormous. There is no really strong, solid mental health system in Lebanon. Even the health system in Lebanon is still suffering very much as a result of years and years of corrupt governance and corrupt people in power. And this has led to the bankruptcy of the government and the fall of the Lebanese lira in the last 10 months, obviously, and this has definitely reflected on the healthcare system and so as well on the mental health care system. And this is why all the any funding right now, in order to tackle the mental health response, which has accumulated times 10 after the explosion, will be very much needed in order to build a national network and not just provide immediate disaster relief. Because immediate disaster relief will only solve a problem of one or help and mediate. It will not solve a problem. It will help and ameliorate a problem for a few months. But we have a whole system of mental health services that we need to build.
Can I add something also? Actually, also, there's a problem, not only the little amount of fund, but also the way they spend this fund. I mean, sometimes we talk about effectiveness, but we forget about what we call efficiency or cost effectiveness. And the way that I see it, even when they are enthusiastic to fund and support mental health, they sometimes do it in a wrong way, actually. And from my perspective, I think is the best way is to integrate mental health and psychosocial support with all other sectors. This is the way where you can provide a comprehensive integrated services to people. And I think with less money, you can do more. But because of this sectorizing the aid and each sector try to maybe advocate more for the needs, and there's like lack of real coordination, because they talk about coordination, but it is not real coordination. You see that a lot of money is spending in a wrong way. The other thing is there's no work on quality assurance of the services being provided. There's some great work that is provided, but mental health and psychosocial support is like widespread and is being done with a lot of organizations. But the quality of that services may be in question. And also we had a problem with the curriculum that is being used. He talked about this info, Dr. Isam, and also the other curriculum, but it is not culturally sensitive. It is not from within the community, their culture, their faith, their needs, their way of seeing things. I mean, no one actually have developed something that from inside the context. And this is very problem. Now, they sometimes say, we need to hear from you. I mean, they say that we need to hear from this humanitarian workers. But what happens usually is the humanitarian workers not giving them the genuine opinions. They give them the thing that or ideas that they think they want to hear. So we are entering in like vicious circle where we ending up spending money and thinking that we are doing good, but sometimes not only not doing good, sometimes we are doing harm. I just want to mention one example actually of this, especially faith sensitive approaches. I did a research among Syrians providers, and 79% of them do some faith activities in their psychosocial support projects. And when I ask them, did you report such activity to your donors? Only 40% of them is providing reports. So 60% of people is hiding such activity because of a lot of other considerations, okay? This is one example about the way that we need to rethink about how we approach psychosocial problems when we deal with a very complex situation. You cannot ignore faith, you cannot ignore politic views of people who have been oppressed and been traumatized for political reasons. You need to take all this into account, but in a professional way. I mean, it can be done to eliminate any possibility for harmful, because it is also not easy to work with these issues, but it needs to be taken into consideration. Now, I don't know how that can be improved, because this is what we are seeing. But then even if like some people will be convinced by that, but you can see there is like establishment of humanitarian aid. So it's difficult to change actually. And there's a lot of, power dynamics where it's difficult to change the paradigm of people. So this is my humble suggestion that if people are interested, they need to be courage enough to rethink, maybe changing all the paradigm of thinking about mental health and psychosocial support with people, refugee and IDPs. Thank you.
Yes, thank you. There is a question coming in asking, are there challenges offering mental health services to communities who may never have been exposed to these services before being displaced?
Yeah, this question is actually, the answer to it is even for me, it's surprising, because I witnessed this on real. It's very easy. I never thought about it. Like when I started doing this 5 years ago, I was thinking that it will be hard. How I will talk with, with Al-Hajji, like 80 years old, coming from Al-Yarmouk, or with a man from Deir ez-Zor, or how I will approach, how he will accept that I am a psychologist or a psychiatrist, and etc. But it was surprising that I'm not just talking, I say never, really. I'm not saying like 1%, never. I witness anyone from any people, I provide him any kind of service inside the camps, shoreline, that he say, oh, psychiatrist, no, I don't want. Yes, I do. In my public clinic, in the public service here where I work, in my private clinic, I see this every day. Please don't mention this diagnosis, or please, this report goes to my family practitioner, and stuff like this. In camps and with refugees is never. And I can explain this only because the people, it's the first time. It's not just I am the good, and it's not that Isam is the angel. No, it's the first time that they come in contact with a person that will ask them, how do you feel? And they are human beings. There's hundreds of people who are with a huge heart and good intention, that they give them food and money and support and saves their lives. They took them out of the rebels. They did all the great things, but none of them asked them, how do you feel? And sometimes it's, we need this. Just like, think about us when we have problems. Like, we need someone to say, how are you? How do you feel? What's about your kid? Are you sad? Are you happy? Do you need anything? And then it's like a magic. And that's why there is no kind of stigmatizing of this service. And this is actually, I can relate it to what Dr. Abu Hilal said. This is about culture, because we think that the refugees are West Eastern and they are primitive in somehow and they didn't receive mental health. They will not receive this this kind of service, and they say no, thank you, we don't want. And this is actually comes from this point of view. But if we think about it, they are human beings and they need this. And when you need this kind of service, it's like this. I never thought, like when I supervised the work we did in Beirut, I never said like people from Al Ashrafiyya were contacting us. And she knows that he was like, say, hi, I'm Muhammad Abu Shawish, I'm psychiatrist from Khartoum, I'm a Gazan psychologist. And I thought, and she was speaking French or English, the lady, and and it was fine. Like there is no boundaries. And for refugees, they lost everything. So what kind of stigma still they need to have? They actually need this kind of contact of human to human, of someone who is really saying, what do you need? And that's why, like, one of the big no of our team, you never ever give €1 to a refugee. Even if you see that he has nothing, like he need the most important medication, don't give even €1. Why? Because this is what will turn you from being his psychologist or his mental mate to the white humanitarian who's giving €50 and €20, and then the relationship will be different. Yes, if he needs a medication, go buy the medication and give it to the Red Cross, and then go to the refugee and tell him, look, you're right. You have the right to ask for your medication from the Red Cross. He will say, no, I don't. No, they say they don't have medication. They only give me the prescription. I say, go and fight for your rights. He will go there and he will say, where is my medication? He say, oh yeah, you have a medication. And then he think that he actually did something, or because he asked for his rights, he took it. It's the same act. I can give it to him directly, or I can give it in indirect way. But in this way, you can actually empower people. In this way, you can make them really understand the importance of receiving this kind of support, and this is what will make them. Because at the end, it's the problem is that there is a state of mind of being refugee. Palestinians are controlled for 70 years as refugees. If they just walk, they will occupy Palestine and Beirut and whole Lebanon. There are millions in the refugee camps. No one will actually tell them not to walk, but it's a state of mind of a being refugee. It's waiting to receive something, and only materials. So it's not about, they didn't receive it or not. It's about just to give this kind of service, and the people will take it because they need it.
Would any of our other panelists like to comment on their experience offering mental health services to communities who maybe hadn't had that experience in the past? Go ahead, Mia.
I think, as Haitham mentioned, it's not being difficult. People really just want to talk. People are interested in others listening to their human suffering. And in terms of, for example, when our volunteers from Embrace went down on the ground in the first 2-3 weeks of the blast, we saw many families, many elderly population, many refugees also who were living in the destroyed area. And people really just want someone to reach out and ask them the same question that Haitham said, which is, how are you feeling and how can I help you? Now, definitely, their most emergent needs are those of basic living and basic assistance. And this is where psychological first aid also comes in as an emergency response, not only to help them psychologically, but to also address their needs. But they do want to talk, and they do want to someone to just be there and to offer their presence. We might not always be able to offer solutions in therapy and in talk therapy, but we definitely can offer a presence that is very much needed, especially during times where all the community is feeling that they are burnt out, feeling exhausted. Embrace runs the National Emotional Support and Suicide Prevention Hotline in Lebanon, which is in collaboration with the Ministry of Public Health. And therefore, that line is open 17.5 hours a day to every single Lebanese and every single non-Lebanese who needs to talk. And people are reaching out strongly. This hotline has been operating in Lebanon for the past 3 years. And now with all the crises that the country has been going through, the demand for the hotline is increasing, and very soon we will be making sure to run it for 24/7, 24 hours a day. So people do want to talk. In communities who have not been exposed to mental health services, if you're just coming in as a human being and you're offering that listening ear, that empathic presence without any judgment, then for sure it will not be rejected by anyone. On the contrary, it will be accepted and embraced.
And also, I want to build on my colleague's speech also. Yes, what people sometimes or most of the time needs somebody to listen to them. This is very important, as Maya said. And also, I want to build on another point that Dr. Issam said. There's a harmful effect of aid, providing aid, without taking psychological consideration. I remember in the first year of crisis in Syria, we were going to people to raise their awareness about their rights, to go to ask for help. But later on, after years, it's become they asking for, and they sitting and just waiting for help to come. And this is very harmful for aid organization to change people from active people to be sitting in the tent or home waiting for help or aid. And this is against the principle of empowerment. So we always talk about empowerment in all our work, and this is need to be mainstreamed in all work in all sectors. And even in psychological support, we don't provide solution for people. We help them to find solution for themselves. We don't tell them to do that or not to do that. We just help them to find their way through their difficulties. We providing them with the skills so they can not live for moment, but also for future. So this concept is very important to be embraced and to be emphasized. And here comes when you don't have the quality services, you find psychological workers just doing orders, advices, and that could be very harmful. Actually, again, I want to emphasize on the quality assurance. This needs to be put in minds of donors. If you don't, I mean, mental health is like easily can be, given wrongly can be conducted. So you need, it is a very sensitive. So you need to be sure that you are recruiting the right persons, you are training them and supervising them so they don't do harm and they improve their service provision. And if we come to the answer, the question, if people, I mean, there's principles when you start a project for psychosocial support. This is international principles. First, you go there and say their needs, even if it's new for them. Ask them, see their needs, and then from their needs, you build a program that suits them. And then you need to recruit people from their community so they can provide services that is culturally and socially appropriate. And just keep their building their capacity and supervision, and always a plan for your exit, so the resources will stay there operating after the crisis is ending. So this is the basic principles actually that any project need to be built on. And this ensures that you reach your goals without any harm.
And this is related to some of the questions that are popping up here. One of the attendees is asking for your thoughts on the potential for community-based MHPSS activities and if how they've observed these activities in the field.
I think that the community is the most important thing. One of our the models that we were supposed to share it in the APA conference in April, but it canceled due to the COVID-19. It's called the inverted pyramid, that's based in the community, and especially inside the refugee community, because we are, as Palestinians, Syrian, Jordanian, Lebanese, people from the Middle East, who are coming from the Eastern mentality that our well-being is a collective well-being. I am in my wedding, I succeed to invite only 600 people. Like, this is after like I make a lot of compromise, and my dad until today he's angry about me, and I reach 600. Why? It's not because this is my well-being, and it's not that the individual well-being in the West is the bad thing. No, there is good and bad in each thing, but the Eastern well-being is a collective well-being. So the first thing that the people lose when they displaced, they are losing their community, and without the community, you are nothing. If you are an Arab, you are nothing. Like, and they lose it because of the trauma. Because when there's a trauma, and when you are in acute state of trauma, and when you activate your fight or flight system, your prefrontal cortex is shut down. When the prefrontal cortex is shut down, you are only surviving. And if you are surviving, you're taking care only about your, children, and that's it. I never saw one boat that has a neighborhood together or a huge family. It's only a father, a mother, and children, even no brothers and like 3-4 families traveling together. Why? Because when there's acute trauma, you run by yourself and you try to save yourself. And then when the fight or flight system is shut down, you will find yourself in a small Greek island that it's hardly exists by itself. By yourself, no one around you, there is no neighbors, no community, nothing. You don't have anything, and you need to survive. And actually what we do as aid workers, we actually emphasize this. We come and say, oh, Arab men are very aggressive. We don't work with men. There's a lot of projects come for women empowerment. Let's empower the women. Okay, safe place for children. So what we do, we cut it more. Children alone, women alone, men alone, and that's it. If we want to work in a context like this, especially refugees who are coming from the Middle East, but it also applies to all refugees and people who are surviving trauma, we need to activate the community. And to activate that community is not by receiving them with the keys of the camp, a 22 years old Danish volunteer who say, oh, poor people, I will take care of you now. No, they are not poor. They cross some mountains and seas and they run away from ISIS. They are not poor and they are not weak. They are stronger than you. You are the problem. You are the one who need to come here to find a meaning for your life. You are a weak person. A refugee who succeeds to run away from Bashar and to cross all of this, he's strong. You can't control his life. Just leave him. We see refugees, a Zaatari camp in Jordan because no one messed with it. He has a 1 billion market in less than 5 years. No one can do this. Syrian can do business. The same as Palestinians, they are locked down in camps for 70 years in Lebanon, and they still survive and do work. And we here inside the Middle East. The problem is what we're facing now in Greece, that we are cutting down actually the community. So if we want to do something, is to rebuild the communities, as the question said, through the activities of community. And to do this, you need to understand the culture. Because if you work with women only, the men will be angry, and you don't want to mess with an Arab man angry when he lost everything as an alpha male. So only to do works like this, you need to understand the culture. You need to work through the culture, through the mentality, not against it. Then you can create the community, and the community heals itself. You don't need 80% of the problems, as our study said, it's solved only if you create the community again. You need only 8%, 88% of people need help really one-on-one after this from professional. The rest, the community can heal it by itself.
can I add something? Unfortunately, it's like ending the session, but I can't agree more with Dr. Issam. I totally agree with all what he said. And I want to emphasize that the best shape of service provision is community-based. Although it is against our, like as the doctors and like specialized, we emphasize more psychosocial community-based approaches. This is what provide the best to the most of people. And the other thing that I want to emphasize also that he opened a very interesting point. Actually, we as Syrians, as Middle Eastern professionals, are able to solve our own problems if we have been empowered, not only in mental health, and even on all other things. The problem is when there's a messing up with all this life that we are living, politics, all this environment. And I call for what I call it like justice therapy. If we embrace justice therapy, 50%, 75% of people suffering from psychosocial problem will have relief. This is actually what we are demanding. And this need a courage from the donors, from governments, to rethink the paradigm of how all things are connected with each other. You can't just sectorize people and do good here and do bad there. So this is maybe my final word. Thank you very much.
Yes, thank you. And any final words from any other panelists? I think Mia, you were going to say something.
I think, yes, what the panelists are saying is that we need to focus on the social determinants of mental health. Without these social determinants, there is no mental health. And it's true that funding priorities go often to provide services, but we also need to improve the social conditions and the environmental conditions in which people are living in order to empower them and to allow them to live in a just environment that provides their basic human rights. And from then on, they can definitely feel that they can access services if they need them when they do.
Well, thank you, panelists and attendees, for your time today. This has been very informative, and you will find this panel online on the website at the same place where the other three that are part of the series are. So thank you again for your time, and I hope you all stay well, and hopefully we'll see each other again soon.
Thank you.
Thank you.
Thank you very much.
Bye,
Thank you.
Thank you.